Welcome, dear patients, clinicians, healthcare professionals, and caregivers. Welcome to our first webinar about heritable thoracic aortic diseases and COVID-19. My name is Elena de Moya, and I'm a patient myself. I'm gonna be your host today, and I'm an advocate at VASCERN. So for those who don't know what or who is VASCERN, then let's see. Here's an overview. So VASCERN is the European reference network on rare multisystemic vascular diseases. That means that we are a network with 37 healthcare providers, HCP, which are hospitals or clinics, and 70 patient organizations from across Europe. As you can see, there are 5 different groups for different diseases groups, and we are represented at HTAD. That stands for heritable thoracic aortic diseases. And in the working group, we handle with the needs and care and drive for patients with Marfan syndrome, Loeys-Dietz, or arterial tortuosity syndrome, amongst others. If you wish to learn more about, then you have a lot of information and some download files for you and your doctors. So I've said that we are clinicians and patients. In the HTAD working group, we are a group of patient advocates, which are 3 active patients, which is Françoise, my deputy co-chair, which is also here today, which she is gonna be reading the chat box. Diana from the Netherlands, which I also saw her in the participants list, and me from Germany, although my Spanish accent says that where I come from. So we are really European. And then we have patient organizations from more than 40 in European countries, which cooperate with us. The full list of all of us and all associations, you can find them in the link. Otherwise, go to VASCERN EU and see the tab for EPAC advocates. You will find the information there. And then we have the clinicians. Professor Guillaume Jondeau is also here today. He is the coordinator of VASCERN and the co-chair at VASCERN's HTAD working group. He will be giving an overview today from COVID-19, what it is, what it makes in our body in general terms, and how clinicians are treating it throughout the world. And the second invited clinician today is Professor Julie de Backer from Belgium. She is the chair of our working group. So she is coordinating the group, which is for Marfan and Loeys-Dietz and all the other HTAD diseases. She will be afterwards in an interview, and she will be answering the questions you, the community, made. And now, please welcome Professor Jondeau, and don't forget to type your questions in the chat box.
Hello, everybody. So I am Guillaume Jondeau from Paris, and I have the task to say some general words about what is COVID-19, which is the disease COVID-19, a disease which is caused by a virus, RNA virus, which means that there is RNA and not DNA in the virus. which is a coronavirus, which means that there are some corona crowd around it that you can see on the slide, and which are the points where it's going to be in contact with the cell. And the name of the virus is SARS-CoV-2 virus. So COVID disease, SARS-CoV-2 virus. The COVID-19 disease, you can separate different phases. The first one, the stage 1, is the early viral infection, and it is associated with constitutional symptoms, non-specific symptoms, just the beginning of the infection. And the stage 2 is related to the direct viral cytotoxicity, which means the destruction of the cells by the virus. The virus goes into the cell and the cell is destroyed. And this is true of the pulmonary system. And because the cell is destroyed, there is an inflammatory activation, or the inflammatory activation allows the destruction of the cell and the virus. And because this virus is fixed mainly in the pulmonary vascular beds, because there is a receptor for the virus, ACE2 inside, then the features, the clinical features, are predominant respiratory system compromised. That can be moderate dyspnea, that can be major acute respiratory distress syndrome, and there is usually hypoxia. So this is the second stage. Then if the host is unable to clear the virus, then you can go into stage 3, which is more specific for this disease, which is a hyper-inflammatory state associated with profound elevations in inflammatory biomarkers. And then you have these manifestations, severe COVID-19 manifestations with multi-organ dysfunction, with ventilation may be necessary, and cytokine storm. Then after that, you may have some delayed immune response that we begin to see, maybe, we don't really know, myocarditis, pseudo-Kawasaki, and then there is a sequela, stage 5, which is a late consequence of COVID-19 disease. This is a new disease, so this is a little artificial and maybe changing with time. Next slide, please. So to make it simple, there are two mechanisms for toxicity in this disease. The first one is the direct effect of the virus, which means that if you are able to fight the virus, you have less of this effect. And if you are not able to fight this virus, you have more of this effect. In patients with HTAD, heritable thoracic aortic disease, there is no indication that there is a decrease in the efficiency of the body to fight this virus. So there is no indication that there is an increased risk for this type of effect. The second mechanism for toxicity is the hyperimmune reaction, which was at stage 3 in the preceding slide. In this hyperimmune reaction, then you expect that people with altered immunity will have a different reaction than those without altered immunity. But there is no indication that people with heritable thoracic aortic disease have altered immunity. So there is no indication, no reason to think that they are more prone to this type of complications than the general population. Then you can think that the disease is more dangerous in somebody who is fragile than in somebody who is healthy. That's obvious. And there is no reason to think that the mutation responsible for the heritable thoracic aortic disease is responsible for fragility. The mutation does not weaken the body. So it's not going to be more severe or the consequences worse in somebody who has a mutation than in somebody who has not a mutation. There is no reason to think that, at least. What weakens the body is previous or concomitant medical problems. And this may occur in every body with or without a mutation. And this is the risk, or this is increasing the risk of the infection, the toxicity of the disease. So these two mechanisms which can be responsible for the toxicity of the disease are those which are looked for by the therapy. You can fight either the coronavirus, by itself or the reaction of the body against the coronavirus. Fighting the coronavirus, you can do this in different ways. The virus is with the RNA, and to make new virus, you will need to make new RNA, which means viral genome replication. And then there are poisons that you can put to not to completely block or limit the viral replication. These are these molecules that are listed here, some of which were designed against Ebola, some are new drugs which are being investigated at present, and these are all common in the fact that they limit the viral genome replication. The second mechanism that can be looked for is protease inhibitor, as we have in HIV infection. Because when the virus is replicating, is translated into protein, what is made, what is constructed is a very, very big protein. And actually, this protein is not functional. To be functional, this protein has to be cut in different parts. And this is the role of the protease to cut the big protein in smaller proteins, which are efficient either as enzyme or structural proteins. So if you avoid this cut of the protein into smaller, active, efficient protein, then you avoid the replication of the virus also. So this is some different drugs. Then you have chloroquine, which may be limiting the endosomal maturation. When the virus is going on the cell, then it goes into the cell with a pocket, and this pocket formation is an endosome, and this is needing some specific features that you can block with chloroquine, or you can expect to block with chloroquine. And then the last way to fight the COVID-19 directly is to give antibodies from patients who had the infection before, or synthetic antibodies. Next slide. The second thing that you may want to limit in this disease is the hyperimmune reaction. And then you are asking immunomodulators. These are anti-inflammatories, corticoids, IL-6 inhibitors, all these drugs that you can see here, which are used in chronic inflammatory diseases, for example, in rheumatology or GI diseases, and which may be helpful also here. And last, the vaccine, just to tell you that there are a lot of vaccines going on. 6 are being currently tested in humans, and 82 are in development. Next slide. So now the risks. The risk of the disease, you can divide them into different types of risk. The first is the risk of being infected by the disease, by the virus, and to get the disease. And the risk is clearly dependent on the immune system. If you have immunosuppression, then you have more risk of being infected. And you know that not everybody is equal in face of infection. And you know that even in the worst diseases, some of the people are not going to get the disease. And so there is inequality there. There is a risk if you get the disease, that you have a severe course of the disease. And we saw maybe the result of the virus, and which is favored by immunosuppression, because you are not able to eliminate rapidly the virus, or which can be the result of the immune reaction, inappropriate excessive reaction. And for this, we have no risk marker. We don't know who is going to have this exaggerated immune response of what we think is an exaggerated immune response. The risks also are not equal in case of severe course. If somebody has a severe form of COVID-19, then it's more dangerous if somebody is weak to start with. So there, the healthy state of the body prior to the infection is important to evaluate the risk. And this is true for all the complications associated with severe neuropathy, mainly ventilation, which is highly stressing for the organism, but it affects all organs when the infection is severe, You can have renal failure, hepatic necrosis, cardiac failure. This is true for all the severe infections. Now, the virus can go specifically in certain organs, and certain organs can be affected by the virus. The immune reaction again. The lungs, we saw that. That's all true for almost everybody who is affected by the disease. The heart, you have the acute phase with infection and later immune response, which is also possible. The vessel, you have at the acute phase a thrombosis. There is an increased thrombosis in this disease, and there is a lot of pulmonary embolism. There have been people reported with leg ischemia, and then there is this later immune response, which is like Kawasaki. There is a GI infection, which can be the effect of the virus directly, and which is occurring only mainly in the acute phase. There can be immune response on the cutaneous level, can be the kidney. So there are various organs, and each of the organs can be affected differently. And then there is a long-term damage, the risk of long-term damage, which is the long-term consequence of the acute alteration of the organ. I think, of course, of the consequences on the lungs. Next slide. Now, what are the risks which have been shown to be associated with death, for example, the risk factors for death in patients affected by COVID-19? So this is one recent study published in a very important American journal, New England Journal of Medicine, with about more than 8,000 patients from 11 countries. And when you try to see which are the factors which are associated with death in this huge population, you can see that the fact of being a male increases the risk of death. The fact that the age is more than 65 is increasing the risk of death. And for the cardiovascular part, coronary artery disease and congestive heart failure are also increasing the risk of death. Coronary artery disease is myocardial infarction, angina pectoris. Congestive heart failure is the fact that your heart is not able to be strong enough to pump all the blood it should pump. Previous cardiac arrhythmias is also increasing the risk with the COVID with disease. And chronic obstructive pulmonary disease, COPD, which makes sense because of the pulmonary aspect of this, which is prominent. And current smokers has been associated with increased risk of death in this study, but in others, not true. What is important here is also the fact that the angiotensin converting enzyme inhibitors or angiotensin II receptor blockades, the Zartans, which has been proposed by some people in Marfan syndrome and other heritable thoracic artery diseases, are not associated with an increased risk of death in this study. Next slide. This is just to stress the main risk factors associated with death in this study, which are age and sex. And this is what happened in France. You have the death, which are the bars, the men on the left, the women on the right, and the age of the population. And this is expressed as the percent of the total population. For example, if you look at the bar at 80 to 89, for the woman, it represents 15%, almost 15% of the whole population of the dead people. If you go into the left, 80 to 89, you see that more than 20% of the dead people due to COVID are men between 80 and 90. So you see that there is more men than women for the same age. And below, you have this, what is called répartition de la population, which is this black line, which is expressing the percent of the population in the different age group. So you see really that what is prominent is that despite the fact that there is less people more than 60 or 65, these are the ones who have trouble with COVID disease. So the major risk factor is age. And the second one is sex, gender. I don't know how you say that. Next slide. So that was true in France, and this is true also in the other countries. So this is a report for 3 other countries, Italy on the left, Germany center or Spain on the right, and you can see there also that being above 60 is a risk factor, and being a man and not a woman is a risk factor. And compared to that, I think all the other risk factors are really limited, much less important. That's all for me, I guess. Thank you.
Yes, thank you very much. I hope that you understand now better what is COVID-19 and which implications it might have, and that's for the general population. So now we go to questions from you, from the patient community. Thank you for all your mails. Julie de Backer is going to give us some answers. So first, hello, Julie, are you there? Julie?
Hi, can you hear me?
Yes.
Yes, I'm sorry. I had some audio trouble. I'm calling in with my phone, so that's why. I'm sorry for that. Yes, hi, Elena.
Hi.
Yeah, hi. So in the second part of this webinar, I'm going to address some of the questions that have been collected by Elena. So thank you very much for doing that. And as you will see, we will try to give some answers. There will be some concrete answers to some questions, but there will be a lot of answers that are maybe a little bit less concrete. And to start off, I would like to emphasize 3 key messages before going into more details. And the first one is that, as you all know, and as is the case in Marfan and in all other heritable thoracic aortic diseases, 2 patients are never alike. So this is already the case within the same family often, that patients cannot be compared with regards to their clinical presentation or to the severity of the disease. And this is also the case with this new disease, COVID-19. So the information that we're going to give will be general information, but always bear in mind that you as an individual have specific issues that need to be taken into account. And then the second message that we want to bring is that no 2 countries can be compared with regards to the regulations and the healthcare system. So rules that apply to country A will often not apply to country B. So we all know that there's different regulations in different nations, and we as this group will of course not be able to provide EU-wide rules when it comes to preventive measures and when it comes to the healthcare system. And then the third message, and maybe the most important one, and Professor Jondeau has already alluded to this, COVID-19 is a new disease to everyone, to the whole world. There's data being collected, but the evidence is weak because there's little experience with this disease. And when we look at the rare diseases of Marfan and heritable thoracic aortic diseases, there's even more lack of evidence. So we try to answer the questions based on the data that have been collected, but many open questions still need further study. So next slide, please. So I'm going to give the word to Elena for each question, and then I'll try to answer them one after the other.
Yes, one thing parallel to us is the European Congress for Rare Diseases, and today in the midday they compared COVID-19 with rare diseases because it's something we don't know much about. There's lack of evidence, and we have to keep on going, keep on getting evidence and try. So now we go to the questions you've made, and the first one is, are patients which are recommended to get the flu vaccination also a COVID-19 high-risk group?
Yes, So this is an interesting question. It already comes back to one of the key messages that I put on the previous slide, which is that there are there's a tendency to compare high-risk groups for flu with high-risk groups for COVID-19. But we have to bear in mind that flu vaccination recommendations vary across countries. So in the US, for example, the CDC recommends an annual flu vaccination to everyone above the age of 6 months. So there's no risk groups, so everyone aged more than 6 months is recommended to get a flu vaccination every year. In the UK, there are some risk groups that are defined, but high-risk groups are also applied to children below the age of 10. And this mainly has to do with the fact that in case of the flu, the transmission of the disease is heavily done by children. So children spread the disease, the flu disease. This is a well-known fact. And in the case of COVID-19 or in coronavirus, the opposite is actually the fact. So children appear to not be the spreaders of the disease. So this is different. In France, flu vaccination recommendations also define risk groups and define people, again, aged more than 6 months with underlying health conditions as a high-risk group. So you can press on the button again, Ibrahim. What I want to say is that flu vaccination high-risk groups are not. It's not as simple as that. It does not correspond to the high-risk groups of COVID-19. And Guillaume has already shown you some data of the high-risk groups, and this is just another representation. This is from a recent study published last week, where they looked at it's a British study done in the national healthcare system. So based on data and healthcare records of 17 million adult patients within the NHS. And you can press on the button again. What I want to show here, so this is how data are often presented in scientific papers. The red dotted line that you see on this graph is the average, and everything that falls on the left of this red dotted line means that you have a lower risk for mortality, and everything that is on the right of this red dotted line means that you have a higher risk. So all the dots that you see on the right of this graph indicate groups that are at higher risk for mortality of COVID-19. And as Guillaume already showed you, the most important risk is age. So age above 60 or above 65, as you like, puts you into a higher risk category. Male sex, already mentioned by Guillaume, is another risk factor that comes out of every study that has been done. Another important risk factor appears to be obesity. So people with overweight or obesity tend to have a worse course of the disease, probably related to respiratory problems, but also, you can go back, yeah. But maybe also to the fact that fat tissue contains some inflammatory factors. So there's a lot of study going on there. Ethnicity plays a role. So Black Americans fare worse than other races. And then lower down, there's a number of other factors that play. But what is important here, so is chronic respiratory disease and chronic cardiac disease. But as you can see, especially the cardiac disease, the dot is not that far on the right of the red dotted line. So apparently, cardiac disease may be less of a risk according to these data. That is, patients who had a transplant, so whatever organ transplant, they need to take immunosuppressants, so drugs that reduce your immunity. And it goes without saying that in the setting of an infectious disease, this brings you into a higher risk group. So just another illustration of what high risk groups for mortality in COVID-19 are, and which patients should be considered as high risk. Yeah, we can go to the next one.
So that's good to know, also to see some graphs and have them explained. It also helps to understand what we are getting in TV or in internet, so we can see how it should be interpreted. And in this graph, and you said chronic cardiac disease is not as much, it's not so far from the line, and this is something we get questions every time. So what is a cardiovascular condition? Which are these chronic cardiac diseases? What is behind that? Is a mitral valve prolapse, or is you had surgery, or you have an aneurysm or dissection?
Yeah, so these are indeed the important questions in this context. So these are data from the European Society of Cardiology, where they give you some idea of high-risk cardiovascular conditions, and Guillaume has already mentioned these as well. So people at a higher risk are patients with heart failure, so meaning that your heart function is decreased and that you require medication to support your heart. So that's one group. Of course, patients with cardiomyopathy and this is disease of the heart muscle often fall into that category and are also at increased risk. And another risk group is patients with significant valve regurgitation. So some people with Marfan disease or related disorders may have significant regurgitation, for example, of the mitral valve. This can co-occur with mitral valve prolapse or aortic valve regurgitation. So in these cases, and when you need medication, again, to support your heart, you fall into the high risk category. And then there's a number of patients, but this is a little less relevant here, with congenital heart disease, so where you have mixed circulations with decreased oxygen saturations that put you into a higher risk. So to come specifically to the questions that Elena mentioned, mitral valve prolapse as such does not put you into a high risk category. It's the function of the valve that is important. If you have prolapse with significant mitral valve regurgitation or insufficiency, and you need medication to relieve you from to relieve your symptoms, then you are in high risk, but not if you have mitral valve prolapse with mild regurgitation. Previous aortic surgery as such does not put you into a high risk group. There's no evidence for this. Of course, if you had your surgery 2 weeks ago and you had a complicated course after the surgery, then that's a different story. But as such, aortic surgery, if you had it in the past, that does not make you necessarily a high risk patient. And the same holds true for aneurysms and dissections. An aneurysm as such, or a dissection which is under treatment and is stable, does not put you into a high risk category for a severe course of COVID-19.
That's good news for many of us. So the next question is if there are any known cases of Marfan patients with COVID-19 and how is their healing process going. I understand that many Marfan units might be closed, or you have been doing telemedicine, but maybe you have heard of some Marfan patients?
Yes, well, of course, there will be Marfan patients who have had COVID-19 for sure, because it affects the entire population. But thus far, we are only aware of a few cases in our centers, and these cases, none of the cases as far as we are aware of, but of course, these are limited data. None of the patients have required hospitalization as far as we know, and all of them have recovered from the disease. So they developed some flu-like symptoms, but patients could stay at the home and did not have a severe course of the disease. So again, this is not data that have been collected within all our centers, but it's what we know thus far.
Yeah, I think we will learn more in a few months, and so. Now some countries are relaxing, others, so many or some of us have an auto surgery in front of them. They ask, should I postpone? Should I postpone my follow-up appointment? Is this wise? And if a follow-up appointment is cancelled, what should I do? And it is safe to go to the hospital. And should we go if we have an unusual issue for COVID-19? Which is not so an unusual issue for marathons, but it might be COVID-19 or not. So something which is not happening usually.
Yes, I think these are important questions. And again, as you say, Elena, there's different rules in different countries, and even within regions of different countries, there may be different rules. With regards to outpatient clinical visits, in our hospital, we have resumed activity. So we have our outpatient clinics, and follow-up visits are going on almost as before the crisis. But I know that in many other countries, this is not yet the case. For your follow-up appointments, you should contact your physician and ask how this will be managed. I think all of us will want to do catching up, so all appointments that have not taken place will be catched up on short term, but the precise arrangements for this will be hospital and nation dependent. It's a little bit similar with regards to surgery. So so elective surgical procedures have resumed at some places, have not yet resumed at other places. But for sure, this should be, you should contact your physician and see how it will be rescheduled in your specific case. If you were scheduled for elective surgery, it goes without saying that this should not be postponed for too long, because once the decision is made, it should not be put on the long run. So please contact your caregivers and see how your appointments can be arranged within the near future, and then you can. With regards, can you press the button again, Ibrahim? Yeah. So if you have a medical condition requiring attention, you should absolutely go and see either your general practitioner, if that is appropriate, or go to the hospital if that is needed. And people staying at home with symptoms, especially with symptoms of if symptoms of thoracic pain, you should go to the hospital. I think hospitals are safer places these days than shops. We all take our precautions. There's very little infection going on within the hospital. So please do not be afraid to go to the hospital. And if you have a medical condition, you should go and seek medical advice and not postpone that for too long.
Thank you. So I get the take messages: call or contact your doctors. They will help you best. And sometimes it takes a while as everybody's trying to contact, but it's worthy. So you get answers. The next question is about medication. We heard some things about statins, and we heard one of the medications many marathon people are taking are statins. So are blood pressure lowering medications working also against COVID-19?
Yes, so this is a relevant question. There's been a lot of debate on ACE inhibitors and sartans because the virus for COVID-19 uses one of the receptors of these drugs, and from the very beginning there were at first people were afraid to give these drugs, and then there were people saying that they might be beneficial. So the debate is still ongoing, but one important study that has recently been published, so also last week, in an important medical journal, looked at blood pressure lowering drugs, and the conclusion of this important study was that they found no substantial increase in likelihood of a positive test for COVID-19 or in the risk of a severe COVID-19 among patients who tested positive in association with 5 common classes of antihypertensive medications, including ACE inhibitors and sartans. So both the European and the American professional scientific societies for cardiology have made statements about ACE inhibitors and ARBs, and it is not recommended for those people who are on these drugs to discontinue them. There's also no evidence to start them in the hope for a better course of the disease. But the main message is, if you are on these drugs, continue taking them. There is no evidence for increased risk of a severe course. So drugs should not be changed.
Yeah, and people taking them, they take them for a reason. So it's good to know that they are not positive for a severe course, or that the science points in that direction. So then we go from the medication to the heart. Is the risk of myocarditis increased for HTAD patients, so Marfan, Loisitz, and all the others which we handle in our group?
Yeah. Oh, this is something went wrong with the image. Anyway, the myocarditis is an inflammatory inflammatory reaction of the heart muscle itself. Guillaume has already mentioned this as well. So this myocarditis can be caused by a direct effect, an infectious effect virus, but can also be caused by the immune reaction that you get with this infection. So it is related to the viral infection, and there have been reports of myocarditis in the setting of COVID-19. Myocarditis is also, well, not commonly, but it can occur in the setting of the flu, so of influenza infection, and the same holds true for corona or for COVID-19. So there is an increased risk for everyone of developing myocarditis, but this risk is not increased in patients with Marfan or with related conditions. So it has nothing to do with the underlying mutation or the underlying genetic condition. There is a risk, but it's similar to people without these diseases.
Okay. Yeah. That was hard. Now we go to the lung. First of all, which are the pulmonary risk or complications with COVID-19 infection? Professor Jondeau already mentioned some things, but maybe you want to say something else on that?
Yeah. So as Guillaume mentioned, COVID-19 is essentially a respiratory disease. So if there's one organ that is affected by this disease, then it are the lungs. Others, this is different from the heart and from the vessels. So in all patients, the lungs are affected by the virus, and it's logical that if you have any underlying pulmonary condition, then you can be considered as a higher risk. And in the setting of Marfan and related diseases, there are some patients who have what we call emphysema. So this is the blebs inside the lungs that are weaker, and where you can have like these bubbles in the lungs, these put you at a higher risk if you have the infection into the lungs and you have this underlying weakness of the lung tissue. Then the course can be worse, but this is not the case in all patients with Marfan and heritable thoracic aortic disease. It's in a subset of patients, a minority actually. There's also an increased risk in case you have severe asthma, which is also occurring more frequently in patients with heritable thoracic aortic disease. And then the third group are patients with what we call restrictive lung disease. So this means that your lung volume is decreased. And this can, for example, be the case if you have had in the past, if you have had pneumothorax with a complicated course, so where a part of your lung is not functioning well anymore, or in the case of a severe pectus excavatum, where you can imagine that due to the shape of your chest, your lungs are compressed and you have a decreased volume, which again puts you at increased risk for more problematic course of a respiratory disease. So these are the main pulmonary risk complications.
Thank you. I see people going to read the letters again and see if they find these words or not. and now they will understand what they mean and will be happy if they don't find them. So you mentioned pneumothorax, but you said once so far, are you at a higher risk, or do you, in case of needing ventilation? Because we've heard severe cases need ventilation. So what is if our lungs are already a little bit weaker?
Yeah. So in the worst case scenario of COVID-19, you will need ventilation, and so to provide you with sufficient amounts of oxygen, and mechanical ventilation. So where you are connected to a machine, especially in the case of COVID-19, requires high pressure to provide enough air and enough oxygen to the lungs. This is the case with everyone. So everyone who ends up to be ventilated in the setting of COVID-19 needs high pressure ventilation because of the severity of the pulmonary infection. And it's conceivable that if you put high pressure to the lungs and to the tissue surrounding the lung where you have the pneumothorax from, that you are at increased risk for developing a pneumothorax. So pneumothoraxes are sometimes seen also in patients with normal lungs when they have high pressure ventilation. So the doctors that will treat you need to know about your condition. This is always the case, but this is in this case very important that they know that you have this connective tissue disorder and that they can take that into account. But to emphasize that having these connective tissue disorders, so Marfan or whatever, is not a contraindication for ventilation. So it's not because you have this condition that doctors should say, so you cannot be put on a ventilator. That is absolutely not the case. They should be more careful and careful in setting the machine, the pressure in the machine, but it does not preclude you from ventilation. Okay,
so maybe we can add that to our do's and don'ts. I don't know if people here know them. So people or your relatives should be aware. If you need to be put into ventilation, this has to be taken into account. And now we are allowed to go to the streets in most places. And sometimes we are asked to close rooms or whatever, or public transport. So is wearing a mask safe for people with Marfan in general, or who have an aorta dissection? And what about the ones which normally have fatigue or air hunger? They feel they are not getting enough air. Is the risk of hypercapnia, that means not enough oxygen, to get not enough oxygen, is this higher in Marfan, or related diseases higher?
Yes, so just the main message here should be that for 95% of patients with Marfan and with related diseases, wearing a mask is safe. Of course, you should have an appropriate mask, There's different types of masks. There's masks that will give you a little bit that are closing your air circulation more than other masks do. But in general, a mask is safe. It's only in those rare cases of patients requiring extra oxygen, for example, who will need to be more careful. But those people are not recommended to go into crowded places anyway. So yes, wearing a mask is safe, and if you need to wear a mask when you go out in your country, please do so. And you should not be afraid of having complications from a face mask, from a simple face mask.
And so we've realized that sometimes it's hot in there, but it's not a problem for us. So that's good to know. And here's another one, which is about vessels and clots. So we have been hearing something that it might attack or it's attacking blood vessels, and we know our vessels are not always best quality. Are we a higher risk? And are people which are taking blood thinners like Macoma and others protected then against these clots or thrombus?
Yes, when looking at the blood vessels, so again, this infection, so COVID-19 is an infectious and inflammatory disease, and as all other organs, the blood vessels can also be affected by this. And there have been reports about people having more vascular complications, but most of these reports relate to well, the more common vascular complications being myocardial infarction and stroke and things like that, which are related to the endothelium and to endothelial dysfunction. So this means that the inner part of your vessel will be affected and will suffer from the inflammation, which can cause obstruction or can cause myocardial infarction and stroke and such. But there's no evidence thus far. Again, we will need more data on the longer term, but there's no evidence thus far that this will lead to more rapid progression of an aneurysm or to more severe, to an increased risk for aortic dissection. There is thus far no evidence for that at all. So at the moment, we have no evidence for saying that there's an increased risk for these kinds of problems in patients with heritable thoracic aortic disease. And then the next, you can go to So there is proven evidence. So there is evidence in the setting of COVID-19 that there is a risk for venous thrombosis. So this is not in the arteries, but in the veins, where you can have clot formation, which is like what you have in deep vein thrombosis, like what can happen in your legs, or there's a lot of cases that have been reported with pulmonary embolism, which is also caused by clots in your venous system. And this occurs more frequently in the setting of COVID-19. This is something that is related to this disease, but again, this is what is happening in all patients with a severe course of the disease, and not specifically in patients with vascular disease. So there is a risk again for clotting of your veins, but not more than in the general population. And then when looking at patients who are under anticoagulants, so Marcomar, like Elena mentioned, there is one study looking at this. It's an observational study, and this study could indicate that patients who are under these drugs may have a better outcome than patients who are not taking these drugs. So patients, for example, who have a mechanical aortic valve and who need to take these anticoagulants may be at a decreased risk for developing such problems, which does not mean that you need to start taking these drugs. But patients who are under treatment may have a better course. And then with regards to vascular problems, there's one other issue that has come up more recently. So this is the issue of Kawasaki disease. So Kawasaki disease is a rare pediatric form of vasculitis. So again, itis means infection, inflammation. It is an inflammatory disease of the vessels, which comes with some other symptoms. So these children also, most of them have a rash, so have red lesions on their skin. Most of them will also have some form of conjunctivitis, so infection or inflammation of the eyes. And the most feared complication in Kawasaki is aneurysms that can develop on your coronary arteries. This is very typical for this disease. There have been some I must say, case reports actually so far of Kawasaki-like features in COVID-19 in children. The exact relationship with the virus is not well, there's no explanation thus far. Again, inflammation and Kawasaki disease may be occurring more frequently in the setting of COVID-19, but this is again the case for every child, for everyone in the general population, and there's no particularly increased risk in patients with genetic conditions of the aorta. So I hope this answers this question.
Yeah, so I think you will be having an eye on these things, how it evolves, and you will inform us as soon as we have news of evidence of positive or negative. But just for the others to know, VASCERN is a evidence base. We always work on evidence so that we build science up and get reliable answers. So number 6, and this is the last question from those who which were handed in. So if you have any question, remember the chat box. What about ophthalmological complications?
Yes, so I just mentioned that there's maybe some increased risk for having conjunctivitis or some inflammation of your eyes in the setting of COVID-19. But there's very little data, if any relevant data on ophthalmological manifestations of COVID-19. So this is very uncommon. And in the setting of Marfan disease, where we have, of course, the issue, the problem of lens luxation, there's no data on increased risk and very likely no evidence or no proven increased risk for patients with lens problems. So I think the eyes are a bit spared in this disease.
Yeah, I think the eyes, like mouth and nose, are just the ways into the body for the virus, but yeah,
exactly.
So thank you very much for all these answers. So I think that how it affect or can affect us, and we've seen that Marfan patients and related diseases for itself, like the gene mutation, has no higher risk than the population, but there are some things to be taken into account. So like, for example, if you have a severe course, please advise that you have a connective tissue disorder so that they can adapt the ventilation and be aware of pneumothorax. But the best is you don't get the virus. So for that, it's very important to follow the general hygiene rules. I know, but we have to say, avoid people who are sick. We know that sometimes it's a birthday. Nowadays, it's a little bit more difficult, but if it's a birthday, you don't feel good, but you go. don't go. Please stay home if you don't feel good or someone who is gonna be there feels sick. Keep a 2-meter distance from other individuals whenever possible. They have been saying it. It's not just contact, it's also when you speak. So if we have this distance, it's better. Wash your hands thoroughly with soap and warm water for at least 20 seconds. I sing Happy Birthday twice, other takes another song, so it takes a little bit longer than other times. And don't forget the back sides of your hands and the fingernails. Cover your mouth and nose when you cough and sneeze, or at the best, do it inside your elbow. Don't touch your eyes, nose, and mouth. Often touch surfaces like door knobs, handles, steering wheels, and light switches, or think about your mobile devices. But be aware that some displays might be some sensible to disinfectant, so please use things that are for mobile devices. Stay at home as much as possible. If you don't go out, you don't have the risk, and including working. So we were asked if telework or mobile working or home working is good. If your employer offer it, it's better. And if he's not offering it, just ask. Sometimes the no is already there, so why not? If you have symptoms like fever, cough, or chest infection, self-isolation. So do it from yourself. Don't wait until someone tells you stay at home. Do it alone. And in some countries, you have telephone numbers where you can call. And in other, you have even a stricter isolation. You have to be in one room, not with your families, like in Italy, France, Spain, or Belgium. So keep the rules in your country to be on the safe side. I don't think that we have forget anything else. I'm taking a look. Oh, we have a question there, I see. We already talked about pneumothoraces, but there is a question what says, Françoise, do you want to read it? Françoise? Okay, yeah. Then I'll do. Oh, okay. Have you seen the questions there?
Yeah, I'm sorry I had no sound anymore. I had to leave the meeting and reconnect.
No problem. It's a mobile webinar. Is the future. So
I didn't listen to what. Go ahead, because I couldn't hear what you said before.
Okay,
so.
No problem. So we have a question which it's partially already been answered, but it's more detailed. Does a couple of recurrent pneumothoraces 15 years ago now make someone more vulnerable if they get infected?
Yeah, is it okay if I answer?
Yes, yeah. You or Guillaume?
Yeah, well, I think it depends. So more vulnerable if you get infected. It's the main issue is when you have a severe course of the disease and when you need to go on the ventilator. So that's the main issue here. We all know, and I think everybody knows that coughing as such puts you at risk for developing pneumothorax. So this COVID-19 being a respiratory disease, yeah, there may be an increased risk for having a recurrence of the pneumothorax. It depends a little bit on how your pneumothorax or the recurrent pneumothoraxes were treated in the past. If you have had a pleurodesis, for example, if you had surgical procedures in the past to treat those pneumothoraxes, then your lungs will be more or less secured more, so they will be less vulnerable in that case. Is in case this if this is not the case, so if you did not have any procedures to cure or to treat the pneumothorax, or did not require any treatment, then of course you are at you are more vulnerable as a Marfan patient as such. So yeah, I would say inform the doctors, make sure that they are informed about the underlying condition and that they can take that into account. And if you don't need ventilation and if it's just the coughing, then an anti-cough medication may be important, or is important, I think.
Okay, thank you. So that is also a take-home message. If you are unsure, contact your doctor. They know you best. They know your clinical records. They know how you are doing. So they can help you if you give them the ideas you took, the notes, and they will tell you what is best for you. And I want to thank everybody. I wanted to say something on that last slide, but it's gone. It's no problem. It was just some social media socializing. So if you want to learn more about us, if you want to hear more from us, just follow us in Facebook, Twitter, LinkedIn, or YouTube. There are lots of videos already, which you can take a look to, which are the pills of knowledge. And you can also subscribe our newsletter from VASCERN at vascern.eu. So maybe this is the first webinar, but we hope it won't be the last one. And if you have questions, send us an email to me or to the coordinator. Use the contact of the website. Thank you very much for everybody attending, and have a nice evening.